would go on to Dr. Prem, who would be giving the keynote address on toxic nutritional and drug-induced optic neuropathies. On to you, Doctor.
Okay, thank you very much. It's my real pleasure to give this talk on toxic nutritional and drug-induced optic neuropathies. This is a very broad subject, and I'm going to refrain from giving you laundry lists of medications and toxins and such, because it's lovely in 2020 that we have the internet and we have these resources in which we can look up all that information. But instead, I'd like to show you several clinical scenarios in which patients with suspected conditions present and how to approach these patients so that you make the correct diagnosis and lead down the correct path. And so I have no relevant financial disclosures with respect to this talk. I'm going to start with a case which is a little bit complex, but speaks to the challenges that we have in making a diagnosis. So this was a 27-year-old woman, and she presented to us eventually with vision loss, but her history was such that she had had other neurological symptoms, lower extremity paresthesias after a diarrheal illness. It was thought perhaps she had a Guillain-Barré type syndrome. She had had some blurred vision at that time. She had falls, problems with writing, even facial pain. And an MRI brain was performed, and this showed minimal white matter lesions in her frontal lobes. They felt that was consistent with migraine headache. And an EMG was performed, which was thought also to support this idea that she had Guillain-Barré syndrome. A lumbar puncture performed showed normal CSF, but a mildly elevated protein, and she was thought again to have an inflammatory neurological syndrome as the cause of blurred vision and systemic or other neurological signs. She was treated with prednisone. Some of her symptoms improved. She was then given, relevant to the conversations we've been having, IVIG over 4 cycles, some improvement in her facial pain, but not in her burning and weakness in her extremities. She took a number of supplements, but she stopped them because she thought they were giving her side effects. She had neuropathic pain, and so they gave her gabapentin and then pregabalin, amitriptyline. All of these discontinued because she was having side effects. And then she reported that she awoke months later with bilateral vision loss. She was 660, 2200 in both eyes, was diagnosed by an ophthalmologist who she saw with keratoconus. But he also thought that her optic discs were somewhat pale. He improved her vision to 20/80 with rigid contact lenses and referred her to the neuro-ophthalmology service, where we found similar visual acuities. She had no RAPD and briskly reactive pupils. She did have some temporal pallor of both optic discs, but I teach my residents that temporal pallor is one of the most difficult diagnoses to make and one of the most overcalled findings in ophthalmology. You can fool yourself by either the presence or absence of temporal pallor. So when it's very obvious, it's easy, but here I think it's a little more subtle. She had visual field testing, and you can appreciate that her foveal thresholds are reduced in both eyes. Maybe having the benefit of hindsight, you can see that she has some central scotoma, central depression, but nothing much that jumps out at you in terms of a specific pattern of visual field loss. There are high false negatives in this, and so you wonder what exactly is going on. Now, we spoke a little bit about the role of OCT in making a diagnosis in patients with optic neuropathies. And we can appreciate here that there is definite temporal thinning. This can again fool you because there is more variability in the temporal sector than there is in any other sector on the OCT analysis. But if we look at the heat map here, you can see very clearly that there is a consistent temporal thinning out of proportion to thinning elsewhere within the retinal nerve fiber layer bilaterally in this patient. So this is looking like this could be something involving the papillomacular bundle, that temporal nerve fiber layer. We look at the macular ganglion cell complex, and maybe there is preferential loss as well on the right, as well as the left eye in the ganglion cell complex that may subserve the PM bundle. But what is really going to help us to make the correct diagnosis in a patient like this is taking further history, getting more information. She reported that she had several months of excessive alcohol intake. She was drinking 10 or 12 drinks per day. And because this was providing most of her caloric needs, she had minimal food consumption. She had an unintentional weight loss of 45 kilograms. She was depressed. She lost her job because of her alcoholism, and she had stopped drinking 4 months prior to presentation. This history had not been obtained by other people who had seen her. And so she had gone through all of this extensive workup for these neurological symptoms. Her paresthesias may well have been thiamine deficiency. Her vision loss certainly fell into the category of a nutritional deficiency because she was not eating. She underwent lumbar puncture, MRI, all sorts of treatment with prednisone and IVIG because no one bothered to take a proper history and to elicit from her that she was alcoholic. I don't know how it is in India, but in North America, unless you ask very specifically, patients will not tell you about their alcohol intake. And if you do not question them very carefully and in a very open manner, you will miss this diagnosis. And the OCT doesn't always help you. These are 2 OCTs from 2 other patients I have seen over the past few years with a nutritional optic neuropathy. The so-called tobacco alcohol amblyopia is really a nutritional optic neuropathy because patients stop eating food, getting all their calories from alcohol. Here, these patients presented later with more profound vision loss, and there's just a diffuse loss of the retinal nerve fiber layer, and there is a diffuse loss of the macular ganglion cell complex in the first and now the second patient. So don't rely on OCT, don't rely on visual fields, don't rely even on your clinical exam. This is a diagnosis made by history. And to further emphasize this 44-year-old woman who had depression and anxiety was referred to me after she was seen by an outside optometrist with mildly reduced visual acuity of 6/15 in both eyes. She had no RAPD, and she had a normal ophthalmologic exam. She denied tobacco or alcohol use. She had lost about 40 pounds in the past several months and admitted to not eating well because she was depressed. And because her vision had dropped below 6/12, she was no longer able to drive and could not drive to the Walmart to do her job. She was sent to me for functional vision loss by the optometrist because she had decreased vision and normal examination. And indeed, by the time I saw her several weeks later, 6/18 vision, no RAPD, unremarkable fundus exam, but her color vision was markedly reduced in both eyes, and using a small red object, I mapped out a central scotoma in both eyes. And when we did 10-2 visual field testing, this did not really show up on 24-2 visual field testing. She had a small central scotoma in each eye that was consistent with the clinical examination, explained her decreased vision. We did serologic testing, found that she was deficient in thiamine as well as vitamin B12. We replenished her nutrients and her vision recovered to 6/7.5 in both eyes, and she returned to a productive life working in society. You can predict to some degree what nutrients might be depleted by looking at how long the patient has had vision loss. Vitamin A takes months. Vitamin B12 can take months to years, as can vitamin E and copper. But vitamin B6 in particular is depleted very quickly over the course of weeks. Folate, depending on the patient's initial status, also can be depleted more quickly. So keep this list in mind. Look for other secondary findings that can go along with nutritional optic neuropathy. But one thing I want to leave you with is that functional vision loss almost never has central scotoma. Patients will have constricted visual fields or generalized depressed visual fields, but when you see central scotoma, functional vision loss should almost fall off your differential diagnosis. And again, take that good history and look for other findings. Why do all of these problems affect the central vision and cause central scotoma? So if we look at the optic disc and macula, we look at how the retinal nerve fiber layers enter the optic disc. We know the temporal fibers and nasal fibers come in horizontally, the superior and inferior fibers come in vertically, and that PM bundle goes directly from the macula to the optic nerve, resulting in that temporal pallor as well as characteristic retinal nerve fiber layer dropout, specifically in the PM bundle that can escape you if you don't look for it early. Why is the PM bundle susceptible? It's most likely increased metabolic demand, the same reason that hereditary optic neuropathies affect the PM bundle. You have more mitochondria, more metabolic demand, and when the nutrient levels fall off, they are affected first. it may be less because of accumulation of toxin. We have some case report evidence of an actual decrease in the multifocal ERG, interestingly enough, in patients who have nutritional optic neuropathy. So that suggests that there may be photoreceptor or even RPE dysfunction in patients with PM bundle disease. And I don't think it's the first to be noticed. It is a specific effect on the axons that serve the PM bundle. A case that many of you are going to be very familiar with, seeing much more TB in India than we do in the Western world. But we are more likely to see patients who are like this, elderly, develop chronic cough, no fevers or chills. She's of Chinese origin, but has lived in the US for over 20 years. She has suspicious lesions on her chest CT, and she has an atypical mycobacterial infection, not mycobacterial TB. And here, those patients are treated with a 3-drug regimen of rifampin, clarithromycin, and ethambutol. And 5 months later, the typical time frame for the onset of a toxic optic neuropathy from drugs, she develops a decreased ability to read books. She has no pain. She's still taking the 3-drug regimen, and in fact, systemically feels well. Her cough is better. She sees a glaucoma specialist, and there's a confounding factor here, as I'll show you. She has decreased visual acuity in both eyes, no RAPD. Her fundus is unremarkable. Color vision was not tested. She sees me 3 months later. Her vision has actually improved because at this point, she has stopped her ethambutol. There is suspicion that ethambutol was responsible for her problem. She has glaucomatous cupping in both eyes, and I'll show you some visual fields in just a moment. But ethambutol optic neuropathy tends to be a dose-dependent disease. It can have an incidence as high as 6% in doses of 25 milligrams per kilogram per day. And there is accumulating evidence that there is ethnic group variability, the presence of modifier genes. I have colleagues in the Philippines in particular who have found a tremendous incidence of ethambutol-associated optic neuropathy. It's rare before 6 weeks of treatment to occur. And cessation of drug may allow visual recovery, and that's dependent upon the extent of visual field and OCT damage. So I'm not going to show you a variety of visual fields and OCTs in these patients because I think it's highly variable. The OCT may be helpful in predicting visual recovery, but this is an example, especially for some of the trainees out there, about how in a patient with glaucoma who already has a characteristic glaucomatous visual field defect, the characteristic central scotoma may be lost. And when the central scotoma develops and becomes more broad, becomes larger, these patients may have a pseudo bitemporal defect. And in fact, when Goldman visual fields were done on this same patient at the same time that those automated fields were done, you can now see a much more characteristic classic cecocentral scotoma in the left eye and in the right eye, going along with her diagnosis of a toxic optic neuropathy secondary to ethambutol. And so the pearl I want you to take away from this, most of us don't have Goldman visual fields anymore, and we get automated perimetry on these patients. A pseudobitemporal hemianopia may be seen instead of cecocentral defects, and if you see a pseudobitemporal hemianopia with the right clinical history, be suspicious for a toxic optic neuropathy. I'll finish by talking about a confounding clinical situation that confronts us still today. When we see a patient like this with a typical NAION, he's hypertensive, diabetic, hyperlipidemia, sudden painless vision loss, disc swelling with an RAPD and a superior altitudinal defect, and a disc at risk in the other eye, we know what this is. This is NAION. But if we take a further medical history and we find out he has not only obstructive sleep apnea, for which he is using CPAP and sleeping better, but atrial fibrillation, for which he underwent a cardioversion 1 year ago. He had sotalol to try to keep him in rhythm, but it was not tolerated, so now he's been put on amiodarone. And so this patient is sitting in your office and says, "Doctor, does amiodarone cause NAION?" We know amiodarone is a drug that was developed for the treatment of angina pectoris. It was initially used in patients with serious arrhythmias like ventricular tachycardia, but is now used more routinely by cardiologists to help control AFib, especially after cardioversion. It has a very long and variable half-life in the plasma, and it is accumulated in lysosomes. The idea that amiodarone could cause NAION came from a Mayo Clinic study over 30 years ago, where they found 13 patients with optic neuropathy out of 447 patients taking amiodarone. And they felt that this was a 6-fold increased incidence of NAION compared to an age-matched cohort. So this developed the idea that amiodarone could be implicated in NAION. Since then, many case reports. In 1997, the package insert was actually modified to list optic neuropathy. But in 2007, a randomized prospective trial demonstrated no increase in optic neuropathy with amiodarone versus placebo. But there is an amiodarone optic neuropathy, and it occurs over months. So 4 examples quickly of patients with amiodarone optic neuropathy. They can have optic nerve swelling, but it's usually some pallor associated with it. There may be some disc hemorrhages. It's usually symmetric, and it is insidious in onset. So it's insidious over months, not rapid over days. It is usually bilateral. Visual acuity is in the 2020 to 2200 range, and disc swelling takes weeks to resolve. At this point, it's been classified as a possible cause, and I think we should consider it in that way. It can cause optic neuropathy, but not NAION. So in conclusion, toxic nutritional deficiency and many drug-induced optic neuropathies affect the PM bundle. History is key to making the diagnosis. Visual fields may mislead you. Drugs damage the optic nerve through damage of the PM bundle and mitochondrial problems, but can also cause problems like demyelination and lysosomal damage. And I'll be happy to take questions from my panelists regarding these matters. Thank you very much.
Thank you very much, Dr. Prem. Questions, Dr. Wyatt?
So, of course, one of the issues which we get a lot of patients of is ethambutol toxicity. And of course, the question often has been asked that how and when would you suspect that there could be INH related toxicity? So we very easily diagnose ethambutol toxicity, but any experience or idea about INH toxicity, Dr. Prem?
Sure. So again, I think many of you have more experience with this than Sachin or I do because of your population, but there are sometimes retinal dysfunction present. There is retinal dysfunction present that can be picked up by electrophysiology. So I have used that in some patients to look for concomitant INH toxicity. Again, it's not something that we tend to see commonly. And so I actually deferred to you to tell me if you have particular etiologies or particular investigations that have been useful to you in differentiating ethambutol from INH toxicity.
Sure. Rashmin, any comments? Rashmin, Ambika, otherwise?
I think there are lots of, it probably would be exclusion and lots of anecdote because there are no studies or there's no data to say that, yeah, this is that. I would say, I mean, this is off the hat that ethambutol would have much more central scotoma and a temporal hemianopic-like defect, the pseudo bitemporal hemianopia. I'm not sure whether INH also produces a pseudo bitemporal hemianopia. And Dr. Bhattu, I think, wanted to say something.
Bhattu wanted to say something.
Yeah. I have seen a patient who was on treatment for tuberculosis spine. He was on INH, ethambutol, and one other drug. During treatment, he suddenly developed a rapid loss of vision. The orthopedic surgeon who was actually treating him stopped ethambutol immediately under the assumption this could be ethambutol, good thinking. But his visual loss continued to deteriorate. He was then sent over to the neurologist in Bangalore who evaluated it, and he sent him over to me, and I found a mild disc edema, just a mild disc edema. His visual acuity recorded about 15 days prior was around 636. Now he was around 5/60. And the optic disc had started becoming pale. One thought occurred to me that this could be a rare situation of INH toxicity. And we actually stopped the INH and referred him to an infectious disease specialist for changeover of medication. he actually recovered very fast after stopping the INH. And this is all circumstantial. But we did suspect on hindsight that it was an INH toxicity to start with and not a primary and ethambutol toxicity. So this is one case report which I have not published, but one suspicion, the strong suspicion that this was an INH-induced toxicity, although it is very rare compared to ethambutol.
Although in experience, we've learned that even after stopping ethambutol, certain amount of visual loss does continue up to even a month.
Yes.
So, I mean, so for the house or for everybody who sees such a patient, please remember, let's not be aggressive in removing ethambutol, which is one of the sheet anchor treatments. So be a little careful when you recommend. Up to a month, you may have a little progression of the visual dysfunction, and which may improve after that. So, of course, this is definitely one of the ways that if you see progressive visual loss, even after stopping ethambutol, consider INH toxicity coexisting. But any other comments?
Ambika, I think Ambika wants to comment.
Yeah, actually, I think when we have ethambutol and INH together, as Dr. Bhattu has rightly pointed, if you see a patient with a normal appearing disc in an early stage of ethambutol toxicity, probably we can watch that patient just plugging him out of ethambutol, provided he has the classical pseudo-bitemporal and all those history of ethambutol dosage being higher. The moment you remove ethambutol, and he will continue to drop in vision. As Dr. Rohit has mentioned, the serum levels of ethambutol will continue to do the toxic effect on the neuropathy. And so just wait for a while. And if a patient presents with bilateral drop in vision and you're suspecting a probable toxic neuropathy, if there is a disc edema, my first choice is INH. Because most of the times INH will cause a bilateral disc swelling along with it, unlike an ethambutol, because I have not seen ethambutol toxicity presenting with disc edema, but I have seen INH presenting with disc edema. And if you pull out a patient having a bilateral disc edema, if it is going to be an INH associated, they recover very fast, as Dr. Bhattu has said. So probably I would go with the appearance of the optic disc.
Dr. Pradeep Sharma wanted to have a word before we move.
From Dr. Prem about the color deficiency, is there any particular color which is more likely to be affected? Like there are some studies indicating the blue color would be more likely to be affected in toxic optic neuropathies.
It's why I like to use the Hardy-Rand-Rittler plates rather than the Ishihara pseudoisochromatic plates, because they do have more of the blue-yellow as opposed to purely red-green. Some of it is color deficiency, some of it is contrast sensitivity loss that masquerades as color vision deficiency. So low contrast acuity may be another way to pick up on an early optic neuropathy in those patients.
I have a question to Dr. Prem. We see a lot of malignancy patients presenting to us with antimetabolites. How frequently you have come across toxic optic neuropathy with antimetabolites?
We see it infrequently, I think, but we have certainly seen it as well. So with the antimetabolites, is there any one in particular that you have found is associated with that? Because I think the ones that we have found is those that affect folate metabolism can then result in toxic optic neuropathy, and they also result in peripheral neuropathy as well. So that's been our experience, that it seems to go along that particular pathway.